Let's start with the definition of hydroxyurea resistance or intolerance. And this is from the ELN. And hydroxyurea resistance is defined as if a patient is on hydroxyurea for basically more than 12 weeks at a total dose of 2 or more grams per day, or a maximum tolerated dose less than 2 grams per day, there's a need for phlebotomy to maintain the crit level less than 45, uncontrolled myeloproliferation, that is, the platelets are more than 400,000 or the white count's above 10,000. There's not any significant reduction of splenomegaly, and there's not a significant reduction of splenomegaly-related symptoms. Hydroxyurea intolerance is defined as the presence of leg ulcers or other unacceptable toxicities, particularly non-hematologic, and there's hematologic toxicity at the lowest active dose. Now, it's important to remind the audience that these are expert consensus and it's not supported by evidence-based data, number one. And generally, these criteria are used to decide which patient should move to second-line therapies. Now, these ELN criteria of hydroxyurea resistance and intolerance were in fact studied by a Spanish group and 261 PV patients. So some caveats. First, that this was a retrospective analysis. The median duration of hydroxyurea therapy was almost 6 years. There was hydroxyurea resistance in 11% of patients according to the ELN definitions and intolerance of 13%. So really you're talking again, as Dr. Rampal indicated, that the number or proportion of patients with PV that have hydroxyurea resistance or intolerance is about 20 to 25%. However, the study did not assess splenomegaly in most individuals, and no patient met criteria for splenomegaly resistance in this study. So what did they find? When they did a multivariate analysis, they found that lack of response to the hematocrit, platelet count, PV-related symptoms, or spleen size did not have prognostic value, so that's important. However, to concede to Dr. Verstovsek, I think it is important, of course, to note that the CYTO-PV study, which we really should take as the definitive study, showed that maintenance of a hematocrit in the range of 45 to 50% is associated with a 4-fold higher rate of cardiovascular death and thrombosis. So, of course, control of the hematocrit is important and does have prognostic value because patients who had a higher hematocrit drop dead. Failure to achieve a white blood cell count response was associated with a significantly shorter survival in the Spanish study. It has a ratio of almost 3-fold, and also hematologic transformation, also 3-fold. So these are Kaplan-Meier graphs regarding survival and risk of disease evolution. And again, resistance but not intolerance to hydroxyurea was associated with a 5.6-fold increase in the risk of death. And both resistance to hydroxyurea and lack of a white blood cell count response maintained significance in a multivariate analysis. And this is just a table from that study. If you look at the bottom 2 rows, again, you see no response in white blood cell count resistant to hydroxyurea. The hazard ratios for increased death or worse survival, and the p-values are significant. And now, I'm not going to go into the details of the way the study was designed for the response trial. Again, Dr. Rampal reviewed this. But regarding the use of ruxolitinib in patients who have hydroxyurea resistance or intolerance, again, you can see that ruxolitinib was superior to best available therapy in the composite endpoint of reduction of spleen volume and also hematocrit control. And the responses were durable, and there were very few discontinuations of ruxolitinib therapy in this phase 3 randomized study. Again, you had significant improvements compared to hydroxyurea with Rux for control of various symptom clusters, and you see the various symptoms on the bottom portion of that graphic. What about thrombosis, which we really haven't alluded to regarding the response trial? Well, through week 32, note, week 32, that was in one of your questions, thromboembolic events occurred in 1 patient in the Rux arm and 6 patients in the standard therapy arm. And there was one additional event in the Rux arm after 32 weeks. And historically, as cited in the paper, if you look at the rate of thromboembolic events in the Rux group, is 1.2 events per 100 patient years, and this was lower than for historical rates for either hydroxyurea responsive or hydroxyurea resistant patients. And you see event rates right there. Now, there were some adverse events of interest with Rux, and again, Dr. Rapal alluded to these, and these include the fact that there was a higher rate of herpes zoster infection with ruxolitinib, and that perhaps is due to the fact that, again, these patients are to some degree immunocompromised, and JAK inhibitors in general thought to be perhaps causing some immune dysregulation, may be contributing to that issue of opportunistic infections. There was also an increased rate of basal cell and squamous cell carcinomas in the ruxolitinib therapy arm, but the major caveat to that is that there are more patients that were randomized to that arm with baseline skin cancer issues. So we really can't make heads or tails about whether this is clinically significant. What about the unaddressed? This study does not answer the question about the long-term control of thromboembolic events with ruxolitinib as it compared to Hydroxyurea-resistant or intolerant patients. We don't really have any questions answered about long-term toxicities of Rux versus Hydrea. And we don't really know or have any idea about whether ruxolitinib in particular can modify the natural history of the disease. We don't have any idea about rates of myelofibrotic and AML transformation, overall survival, and we do know that in the study there was not any significant reduction of JAK2 allele burden, or perhaps around 11%. So really, to get to the debate issue, this study does not pertain to BV patients who are responding, tolerating, and happy on Hydrea or alternative therapies such as pegylated interferon alpha. And I provided you with a very nice graphic of Pharrell Williams showing how happy he is. So let's get to another trial which looked at the value of ruxolitinib in patients with PV, but this is a different patient population. So the RELIEF trial, which was published in abstract form by Mason colleagues in the end of last year, this was a randomized, multi-center, double-blind, double-dummy phase 3b study of patients with PV on a stable dose of Hydrea therapy who were reporting PV-related symptoms. Patients were required to be receiving Hydrea for at least 3 months or so on the same dose level for at least 4 weeks and have a relatively moderate to high score on the MPN-SAF, as well as the cytokine total symptom score. Patients had to meet at least one of the following criteria: less than one phlebotomy in the prior 6 months and no palpable splenomegaly. Patients were randomized to receive in a 1-to-1 fashion Rux 10 BID or Hydrea placebo or Hydrea with Rux placebo. And the majority of patients in the Rux and Hydrea groups did not have baseline platelet counts or white blood counts above the ELN threshold. So again, this is a population of patients who, for the most part, did not meet criteria, ELN criteria for Hydrea resistance or intolerance. So what did the study show? Well, first of all, you had around 50 to 60 patients randomized to either arm, and you can see that the compliance or maintenance of therapy was good through week 16. The proportion of patients achieving a greater than 50% reduction from baseline in the symptom scores at week 16 was about 43% in the Rux group and 30% in the Hydrea group. And notably, this was not statistically significant. Interest, even patients maintaining the same Hydrea dose from prior to study entry through week 16 reported symptom improvement. So about a third of the patients had symptom improvement despite no dose change. 4 to 12 patients had a symptom change with a dose increase, but none with a dose decrease. And if you look at the table regarding changes in symptoms, you do see that the median percent changes in the symptoms were generally more with Rux and Hydrea, but the primary endpoint was not reached in this study. So let me just quote for you what the conclusion of the study was by these authors. In generally well-controlled PV patients receiving a stable dose of Hydrea, there was a positive trend in symptom improvement for patients switched to Rux therapy versus those continuing on Hydrea, although this was not statistically significant. The 34% response rate among patients who continued to receive a stable dose of Hydrea suggests a placebo effect that led to an underpowered study. Well, that is certainly a possible explanation, but at the end of the day, this was a study that did not reach its primary endpoint. Again, a study in patients who are not mostly Hydrea resistant or intolerant. So that is something that Dr. Verstovsek will have to respond to when he follows me. Okay, as Dr. Rampal alluded to, there are other therapies that could be quite attractive for patients who are those beside Hydroxyurea-resistant or intolerant PV. And quickly, this is from the Collagen study with pegylated interferon alpha 2A. This was a dose escalation study from 90 up to 180, and you can see that there's a very high CR rate, which was maintained. A majority of patients had significant reductions of JAK2 allele burden, and there was a real discontinuation rate, which is the theme of any of these forms of interferon. This is a longer-term follow-up study looking at molecular analysis of patients treated with pegylated interferon alpha 2A in both PV and ET. And again, as Dr. Rampal alluded to, you can see that the complete hematologic remission rates are on the order of 75 to 80%, and you can see that a substantial proportion of patients will have some molecular remission. It's about, this is cut off, but around 18% of patients had a complete molecular remission, and you can see that with time, or with prolonged follow-up, that the median allele burden of JAK2 V617F goes down from about 60 to 70% down to below 10%. And then you've got some other formulations of long-acting interferons. There's the so-called pegylated interferon alpha 2B. And again, really not going through all the data here. The same themes are that you've got a high complete hematologic response rate. You've got reductions in JAK2 allele burden that are quite significant. And you've got about 20 to 30% of patients that could discontinue therapy with prolonged treatment. Now, this is actually the title of a piece that was published by Dr. Mascarenhas and colleagues last year in Hematologica. And again, before we start throwing JAK inhibitors to other patient populations in PV, they're not Hydroxyurea-resistant or intolerant, we need to be mindful of this. Optimal therapy for PV and ET can only be determined by the completion of randomized clinical trials. Dr. Verstavsek. And so an example of this is that the MPD Research Consortium has a trial that's looking at high-risk PV and ET patients, and this is the type of trial you want to do. You want to do a randomized trial of Hydroxyurea versus pegylated interferon alpha 2A. This will take some time to accrue, but this will answer the question about whether one drug is superior versus the other and what the tolerability and safety profile is. So when we look at the core issues with the available drugs, or the most commonly available drugs, we have the issues, I think, in my mind, are really tolerability and disease natural history. Regarding tolerability, we know in Hydroxyurea it's usually good tolerance. Yes, there's about 13% or 10 to 15% that may have issues. For interferon, the tolerability can be an issue. There's about a 20 to 30% dropout rate with time. And Rux, I will concede, is a well-tolerated drug for most patients. Regarding alteration of disease natural history, I think that many of us would consider Hydroxyurea cosmetic in this regard. For pegylated interferon alpha, we know that there are substantial reductions of JAK2 allele burden. We know that with long-term follow-up that there are very few, if no, vascular events that are recorded. So if you basically extrapolate from the CML experience, where we know that very deep molecular emissions do seem to alter natural history, this is something that may be feasible with this drug, although not formally known. And ruxolitinib, we have no data whatsoever to know whether this drug alters natural history of PV, of course, because that would require a very long-term study. So let's get off the issue just for a moment about whether drugs are good or bad in terms of safety and efficacy. Let's talk about financial toxicity. And Dr. Verstavsek will have to respond to the chairman of this department, who on 60 Minutes said the only drug that works is a drug that a patient can afford. And so I think that we as physicians need to be good stewards of our patients. We need to advocate for them, not only in terms of their disease, but their financial status and what they can afford. And this is also a healthcare resources issue. So we need to be mindful of all aspects of the care of a patient, not just whether a drug shows a p-value that's significant in an efficacy analysis in a phase 3 study. So let me summarize. Should JAK inhibitors be more broadly applied for patients with PV? And I'll just say no, because that is my debate position. We cannot infer data from the response trial to other PV patient subpopulations. The relief trial for symptom control did not meet its primary endpoint. We need a randomized double-blind double dummy trial versus best available therapies with short and long-term endpoints in high-risk patients who do not meet criteria for Hydroxyurea resistance or intolerance. And again, the issue of financial considerations. And it's very easy to get into this habit of off-label use of drugs, but I think we need to be a little bit more diligent and careful about just throwing drugs out there for indications for which we haven't had rigorous studies. So with that, I'll end my debate stance and give it over to Dr. Verstovsek.